Three, two, one. Recording is started. We can start now.
So, good evening to all of you. Good to see you all. We are back again with another session of the much awaited masterclasses by Dr. Abha Majumdar, ma'am. The topic for today is a very tricky one for all IVF clinicians. It is recurrent implantation failure. Over to you, ma'am.
Thank you, Bhavani, and thank you, Vishal, for hosting us again for this masterclass. It gives me an opportunity to read a little more, and the more I read, the less I know. So let's see that I can sort of, it is my enigma also that I really are looking for true answers in true cases of recurrent implantation failure. So we started understanding implantation as a different part of reproductive success only after the birth of the first IVF baby, Louis Brown, in the world. We started understanding that making embryos is one part and implanting them is another part. And hence, the concept of implantation came into our knowledge, into our reproductive medicine. And every single menstrual cycle aims at endometrial growth and receptivity, targeted to create a window of implantation. This is the way the human gene would continue, the generations would continue after generations, that we have to have our progeny. And for that, humans have a very restricted window of implantation. You'll be surprised to know that other species have all across, for months together, the implantation window open, and they can implant as many embryos. And even our tubal mucosa has the implantation window open away from the endometrial implantation window. And most of the animals, the tubal mucosa is always open to implantation. So anyways, it spans from day 20 to 24 of a 28-day cycle. So it aims at one single function: make the endometrium receptive to embryo implantation so that we can have the next generation come in. And only after development of IVF, it was understood that implantation failure is a major rate limiting step in happening of a successful pregnancy. So we do not know how many cases of unexplained infertility come to us where possibly everything is happening in vivo, but implantation is failing. But we can recognize it only in IVF when we see an embryo in front of us and we put it into the uterus in a very appropriate, supposedly a very appropriate window, and yet it doesn't implant. So what is implantation failure? It is either defective seed, which is embryo, or defective soil, which is the endometrium, or environmental factors, which is around the defective seed and defective soil, or it could be the crosstalk between the seed and the soil. So, having said that, recurrent implantation failure had so many definitions in the last 20, 25 years, or maybe more after the birth of Louis Brown. And the last one was by Kulan et al. In 2014, where he considered only women under 40 years of age. And there it was that if we have more than 3 attempts of embryo transfer of 4 good embryos, they could be day 3 embryos, eight cell embryos in those 3 attempts, or 5 or more blastocysts in those 3 attempts. And this was in the year 2014. So all the data which was taken was before that. So what is very important is that the transfer of good quality embryo should be a necessary prerequisite for the diagnosis of recurrent implantation failure in infertile patients treated with ART. According to the recommendations of the Istanbul Consensus, good quality embryo evaluation should include morphokinetic assessment and the ploidy status, also along with the morphology. So they say when you say a good quality embryo morphologically looks excellent, then also look at the growth rate of this embryo and the ploidy status. But please understand, one thing is very, very clear. We need to differentiate recurrent implantation failure from recurrent IVF failure. Recurrent IVF failures, which are due to inadequate embryos, not very good embryos, multiple embryos are put in because the implantation rates of the clinic are very low, and hence we do not call it as recurrent implantation failure. These are recurrent IVF failures where you are either unable to make embryos, unable to take them to blastocyst stage, even if they are on day 3, they don't look so well. And now we don't do the aneuploidy status on day 3. So we generally want to take them to blastocyst status. So what happened, this definition continued, but we thought this was very inadequate for all the patients. And hence, again, the definition of RIF was established recently in 2023 by the ESHRI Working Group of RIF. And what did they say? It is a secondary phenomena of ART and it can only be observed in patients undergoing IVF. We cannot observe this in natural pregnancies, saying that this unexplained infertility could be due to RIF. And there is so much ambiguity in the definition to date that it is recommended that we must have the following description of RIF to say that, yes, this is RIF. It describes a scenario in which transfer of embryos considered to be viable has failed to result in a positive pregnancy test sufficiently often in a specific patient to warrant consideration for further investigations or interventions. I'll explain this further to you. Like, say, you have to know your clinic's implantation rate. And what I'm saying is not pregnancy rate. I'm talking about implantation rate. And if the implantation rate is 25%, that is when we start putting 2 and 3 embryos to get a pregnancy rate of over 60%. So when we say somebody has reached the competence rate of implantation rate, then it is around 25% or maybe 30%. When we say someone has reached the benchmark of implantation rate, then that is over 60%. So here, what they say is that someone who's undergoing ART treatment, you have basic fertility workup, you've went through at least 2 embryo transfers, and when they say only 2 embryo transfers, we're generally talking about blastocysts, which have failed to result in a pregnancy. Now, you look at that patient, what is her age, what are other factors which could reduce her pregnancy rate, and look at her cumulative chance of having achieved implantation in that particular laboratory. It is very important to consider the laboratory's implantation rate. If the implantation rate is low, then generally 2 embryos is the rule to be put into the uterus. Now, suppose you thought that your implantation rates are 40%. You've done 2 embryo transfers, so the implantation chances should have been more than 60%. In that case, suspect RIF. But if your cumulative chance of pregnancy was less than 60%, you've got a 15% implantation rate. You've done 2 embryos transfer twice. You've not reached the 60% mark. What do? Proceed with another embryo transfer. Don't start investigating or even labeling her as RIF. But yes, when you reached a more than 60% cumulative chance of implantation or pregnancy rate, that is when you start thinking that, oh, she should have implanted by this time more than 60%. She's not. So let me look at RIF. And that is when you start counseling patients on their chances of pregnancy and the relevance of further testing and treatment both. So there have been IVF predict calculators also, and this is a relatively newer concept, though it is being used for some years. Now, on this IVF predict calculator, what do? You see that the woman is 36 years, so not younger than 35, not older than 37. She's been trying to conceive for 3 years and she's gone in for tubal factor. There's no other factor inside, and her own eggs have been used, and she's never had IVF before. Now, this is the laboratory's chance of live birth per IVF attempt is 23.8, and her chance of pregnancy per IVF attempt is 27.6. Now, what do you say? That you've done 1 embryo transfer, whether you've put in 1 or 2 depends on the implantation rate. But if the chance of pregnancy was around 27%, then after 3 attempts, her chances of pregnancy should have been 62%. After 4 attempts, it's 72. And after 5 attempts, it's 80% in this 36-year-old girl. So when do we call her RIF? After she's reached the threshold for RIF that is more than 60%. So you see 62% over the course of 3 ETs. So once we've done 3 ETs and we've not achieved a pregnancy, then we say, oh, this looks like RIF. You may put in 1 embryo, 2 embryo, depending on your implantation rates. If the implantation rates are 15%, you will put in 2 to reach at least a 25-30% implantation. So this is how they calculate through the IVF predict tool. Now, everyone doesn't have the tool. So what gross things you can see? It is again, it is recognized that carrying our individual calculations per patient may not always be feasible. An alternative approach could be to make an estimation based on the clinic's pregnancy rate. And when we say clinic's pregnancy rate, then you see whether that rate is achieved by 2 embryo transfers or 1 embryo transfer for specific patient groups. For example, presented in the table published pregnancy data were used. Now, you see, age has become the most important determinant of implantation rate or pregnancy rate. Now, the above chart, this one which you see embryos of unknown euploidy, here it is important to see the age of the patient because we don't know what euploidy it is. And the implantation rate and pregnancy rate could be 30%. The moment the age goes up, with the same embryo, the implantation rate, pregnancy rate goes down, and 40 and above, it goes even lower. We don't know the ploidy. So what do? We see where has it reached the 62% mark and 60% mark and gone above it. Here, then you see here, and then you see here. So what are the results? That if the woman is younger than 35, intervene after 3 embryo transfers, whether you've done 1, 2, or 3, depending on your implantation rates. If she's 35 to 39, intervene after 4 times embryo transfer have been done. And if she's more than 40, then intervene or start investigating after 6 embryo transfers. To please understand, you have to be patient. You have to convince the patient that, see, your age is such that your implantation rate is, I mean, your chances of getting pregnant would be 1 in 6 embryo transfers. So this has to be explained. But if you've done a euploid embryos, you've done a ploidy test, then what happens? Age almost loses its relevance. After 2 ETs, everyone is reaching a more than 60% first ET implantation rate. And hence, the intervention has to be after 2 failed euploid embryos. Now, having said that, I'll come to the causes of RIF. The one we think is most common is uterus and its cavity, and embryo morphology, growth dynamics, failure to hatch, and euploidy. This is important, but we have to switch these two. I think number 1 is the embryo and number 2 is uterus and its cavity. And the third one is environment, whether it has got any problems around the uterus, which can sort of reduce the implantation potential of that endometrium. The HOXA10 receptors, the alpha-5, beta-3 integrins, are they lower in this patient due to a hydrosalpinx, which is sitting on the side of the uterus, or endometrioma, or there is a parental karyotype, which is deterring the implantation, or fresh transfer COS cycles. And then when all these 3 are excluded, then we come to the 4th group of unexplained RIF. So what can we treat? What we know, we can treat. What we don't know, we cannot treat. So we can treat endometrial defects. We can select a good embryo, make a good one and select a good one. And we can maybe look into the environmental factors. In endometrial defects, how can we treat? We can do surgery if we find a problem. We can give medical treatment and we can do genetic analysis. Same way in the embryo, we can see morphology and growth dynamics is very important. The best embryo is number 1 to be transferred. We make blastocyst and then transfer because we select out all the less adequate embryos, and we can do an assisted hatching. But this is not really very popular now because frozen embryo transfer is so prevalent, and for freezing embryos there is a hole which is made in the embryo, and which sort of lets the embryo hatch more easily. And last of all is pre-implantation genetic testing, especially aneuploidy test, and environmental factors. We'll come to this. You can see everything around the uterus, in the pelvis, or in the system, immune system, which could affect implantation. Having said that, uterine endometrial defects, I told you 3 ways. One is I'll just go back to the diagram. I went very fast. Surgical, medical, and genetic, right? So what are we seeing in the uterine defects? We could see hysteroscopically, we could rule out a lot of things. I mean, we could treat, and laparoscopically, we could treat maybe a myoma, which is a type 2 or type 1 myoma protruding, or there is a type 3, if you go type 3 myoma, but it's large. It's 3 centimeters, 4 or 5, and there is recurrent implantation failure. We can laparoscopically remove it. Then we come to medical treatment. What is a medical treatment we can give to the uterus or to the endometrium? Thin endometrium, thick endometrium. And surgical, I did not talk. I just said laparoscopy is used, but yes, sometimes we also use medical treatment to reduce diffuse adenomyomas, to bring the size of the uterus to optimal size for implantation. But then in medical treatment, we go for mainly endometrial thickness. And if it is thin, then we have two formulas: increase blood flow and increase stromal proliferation. For thick endometrium, you have to give progestogens to bring it down to normal. So what do we use for thin endometrium? This is the most prevalent thing. I feel we've gone paranoid on the endometrial thickness. A patient today canceled her ET only because her endometrium was 6.6 millimeter, triple line, beautiful endometrium. And her OCR endometrium was also the same, but they said, no, no, we've been told that 7 hona chahiye. And they canceled the ET and went away, said next month we would want to try again for the endometrium. So we are paranoid and we make our patients paranoid about this thickness of endometrium. If it's a nice, clean endometrium with no intervention done in, then whatever thickness you get is what the patient will make. So these are the treatment options which are there, which people use most commonly. Stem cells I have not written because they are not that common. And the last is genetic, where we do ERA test to see whether the window of implantation has moved a little bit forward or backward. We look at the microbiota, whether she needs antibiotic treatment, and do a personalized embryo transfer accordingly. So this is for the uterine defects. And please remember, implantation failure and thin endometrium are not synonyms. A thin endometrium could implant very beautifully. Implantation failure could happen in an absolutely normal looking endometrium. So then we come to the second important, whereas I would say that this is the first and the uterus is the second, selecting a good embryo. And morphologically, the best embryo, equal blastomeres, minimal fragmentation, cell number equivalent to embryo age, blastocyst. There is already genomic activation, selection of best embryo, and highest implantation of the blastocyst. Embryo growth dynamics by time lapse, or if you're doing a sequential culture, then you can even see that the embryos are okay on day 3 and then how many proceed to day 5. And last of all is assisted hatching and pre-implantation genetic screening. So assisted hatching is generally recommended where there's previous RF. But when we given embryos to put into the uterus, a lot of times we hear they say it is a hatching blastocyst, it's a completely hatched, it just started to hatch. So generally hatching is not a problem in frozen embryos because already there is a hole and the hatching process does happen. And age, higher age, thick zona, all these are indications for assisting hatching. So when we say all this, I would want to bring your attention to what is happening recently. And recurrent implantation failure, gamete and embryo factors, this is coming up since last decade. People are trying to point their finger to an embryo, but we feel, oh, perfectly looking blastocyst, euploid has to implant. No. IVF laboratory is now becoming the most important place where we think the occurrence of RIF comes from. We need high quality standardized culture media as fundamental to the success of any IVF program. Inadequate culture conditions could play a role in RIF. Essays to identify suboptimal components of a culture system that could lead to impaired embryo development have been described. These include osmolarity testing, pH measurements, sperm bioassay, and all in all, I would say temperature regulation of the embryos while they are growing. In some instances, RIF individualized specific culture conditions may be required for optimal embryo development. The euploidy status of a perfect looking blastocyst may change even in younger women due to inadequate laboratory conditions and temperature variations. And this I heard in the recent fusion conference from the master who's talking on RIF. He said that in young donors, they started doing aneuploidy test, and they took embryos from different labs, and they found that the aneuploidy status had increased from certain labs, and that is due to poor culture conditions. So we have to remember that even young women who have normal eggs could make poor embryos if the laboratory conditions are not good, and they may still come out with blastocyst, but which may not be euploid or which may not be the best. Environment, yes, endometriosis, adenomyosis, we all understand. I didn't tell you on the surgical treatment, but we can give GnRH agonist for 3 to 6 months pre-IVF or pre-ET, significantly increases ongoing pregnancy rate by increasing the endometrial receptivity by upgrading the alpha-5 beta-3 integrin. This is known since long. And now with adenomyosis, this is coming up that as the uterine volume grows over 100 cubic centimeter, the implantation rate is inversely proportional to the size of the uterine cavity. And hence, we like to reduce the sizes of uteruses where there is large adenomyoma. When there's diffuse, then we like to give medical treatment. And if there's localized, surgical treatment could also help. Then comes hydrosalpinges. We are quite crazy about hydrosalpinges, but it only lowers the implantation rate by 35 to 50%. So if you have an implantation rate of say 60-65%, the patient will still implant in almost 35% cases, but in the remaining may not be able to implant. So removal of clipping of tubes can bring it back to normal. Yet, please remember that don't clip every hydrosalpinx because they do not finish off the chance of pregnancy. They only reduce it. Then drugs for ovarian stimulation, when we have high doses, high number of eggs, then progesterone can start acting on the endometrium even before the oocyte retrieval, and hence the endometrium could be, already receptive before we reach a day 5 stage of embryo in the laboratory. And when we put it, already it is post-receptive and hence may not implant. Same way, parental chromosomal translocations are also seen with increased frequency of RIF because of the translocations and should be part of the RIF workup. And then I come to the last one, which we sort of, because what you don't know, you try to explore there. What you know, you see it's not there. And hence you can't do anything about it. But what you can't see, you think that we can tell everyone that possibly this is the cause because we don't know a way to find out. And hence we will treat with everything possible for this. So there is a big question mark on the immune acceptance of the body. However, we feel with so much studies, so many papers, so much publication that it may play a role. So what is unexplained RIF? If the uterus and cavity is normal, embryo is normal, environment doesn't have any negative thing, then we say now if there is recurrent implantation failure, then this is unexplained. And then is unexplained RIF due to defective immune crosstalk between embryo and endometrium? This is what we know least, and that is why we treat most. So with all type of empirical medicines, we go on treating it. Like it has the same fate as thin endometrium has, that the poor thin endometrium, which is very normal for that patient. I mean, a girl who's 5 feet, we want to pull her up to 5'5". Same way, endometrium, which is born 6 millimeters, we want to pull it to 8 millimeters, may not happen. Yes, if it has a problem inside, there are synechia, there are lesions, there are adhesions, they need to be removed. But if there's nothing and it's a clean endometrium, let it be. As much as it grows, it will implant. So we all know that, the immune system, T cells play an important role in immunity during pregnancy. And this has been extensively studied in recurrent pregnancy losses. Th2 cell dominance is essential for normal pregnancy to continue. Imbalance of Th1 to Th2 is associated with reproductive dysfunction or failures. So in patients with RIF, they've seen that Th1 to Th2 ratio is increased. That means Th1 gains dominance over Th2. And possibly this could be one reason for implantation not to happen yet. What is the aim of immunotherapy? We don't know what is there. We just feel that there could be a immune problem which is not leading to implantation. So what we want to create a pro-implantation environment. So what do we use? Either we use steroids and IVIG in the hope that it will modulate T and B cells, natural killer cells, CD56, monocytes, and macrophages. What will it do? It will down-regulate antibody function, like we do give steroids for everything. If there's an allergic reaction, there is a antigen-antibody reaction. To reduce the reaction, we give steroids and IVIG both for this. So this is what they do. We use lit and intralipid in the hope that intralipid and as well as lymphocyte immune therapy will coat the trophoblast so that embryo is undetected by the maternal immune system. It just coats and the embryo comes and sits as a foreign body, but the body is not recognizing. And the last is, a lot of people like to see natural killer cells, but if you see peripheral natural killer cells and uterine natural killer cells, both are part of immune system and they express surface antigen CD56. But they are both phenotypically and functionally different. Less than 10% of the peripheral natural killer cells resemble uterine natural killer cells, and they have significant cytotoxic activity, whereas uterine natural killer cells only appear in mid-secretory phase and they have very little cytotoxic activity. Now, how do we quantify little and more? How do we quantify uterine and peripheral? Yet we go on testing the peripheral blood, and these are extremely expensive tests. Do you know what is the cutoff for natural killer cells in the uterus? I don't know. Do you know what is the cutoff for natural killer cells in the periphery? I don't know. So it is very difficult for the laboratories to give you whether this is normal or raised or low. And their cytotoxic activity of the peripheral NK cell is much, much more than the uterine this thing cytotoxic activity. So we know very little about what is happening in the immune system and whether it is the immune system responsible for this RIF. Hence, we have other options also. We thought now we cannot do much with immune system. Studies come to say yes and no, yes and no. What are the other options? When one is, we thought genetics might help. So endometrial receptivity array was developed. And when it was developed, the group which developed it conducted this 5-year multi-center randomized controlled trial comparing personalized frozen and fresh blastocyst transfer in IVF. Now, look at the irony of this study. Multi-center open label RCT, 458 patients aged 37 years or younger. So one is they took younger patients with blastocyst transfer. At first, embryo transfer were randomized to personalized embryo transfer guided by ERA or fresh embryo transferred in 16 reproductive clinics. So you think that 458 in 16 clinics means every clinic had 20, 30 patients. Protocol analysis demonstrates statistically significant improvement in pregnancy implantation cumulative birth rate in PET compared with FET. So they said it's FET of fresh embryo transfer versus PET of frozen embryo transfer. See, the difference comes here only, that you do a ERA test and you do a personalized embryo transfer guided by ERA. This is the first embryo transfer for that patient, or you do a FET or fresh embryo transfer, FET or fresh embryo transfer in those who are not tested. And what did they say? That statistically significant improvement in pregnancies in the personalized embryo transfer group, indicating that potential utility of PET guided by ERA test at the first appointment. So they've not seen RIF cases. First time patient had a embryo which was made, first IVF which the patient underwent, they divided them into two groups. One underwent ERA and then had the embryo transfer, other did not have ERA and had the usual embryo transfer, fresh or frozen. And they looked at pregnancy rates and they said, oh, personalized was much better. Well, couples with recurrent miscarriage, more than 2 previous biochemical pregnancies or spontaneous abortion, implantation failure, more than 3 failed IVF cycles with good quality embryos transferred, or those who had severe male factor infertility, fewer than 2 million spermatozoa, were not eligible for this study. So this study fails to show that ERA has any good effect in RIF. And we are analyzing our data also, because I also did a lot of ERA in my patients, whereas one or two of my colleagues did not resort to ERA, and we found the pregnancy rates are similar in the third embryo transfer. So we did ERA after two good embryo transfers, blastocyst, made at our center only embryos, so that we know that our implantation rate is around 60%, and hence if two fail, then we should start investigating. And we found the same pregnancy rate in patients who underwent a personalized embryo transfer after ERA, or those who did not have a ERA and went the third embryo transfer. Then we thought, let us see, low molecular weight heparin is probably useful in recurrent pregnancy losses. Maybe it will also have a good effect in RIF. So because heparin does prevent placental thrombosis, infarction, and it promotes an establishment and continuation of pregnancy. And since we've seen APLA can be associated with RPL, RIF, the low molecular weight heparin has been expanded to patients undergoing ART, even in the absence of thrombophilia. And a meta-analysis was conducted, but it did not show any effect in RIF, which means three failed ET. Yes, some studies did show some good effect of this drug on RPL, but not in RIF. But it has a good safety profile in pregnancy, even if it may cause bruising and bleeding. So people still tend to give it. Even I give it. Then came endometritis, and we thought that we must investigate for chronic endometritis. And chronic endometritis is described in patients with RIF with bacterial colonization, even without signs of infection, and can lower the pregnancy rate. C can be diagnosed by hysteroscopy and then hemotoxylin and eosin staining and CD138 labeling. Other diagnostic tests for CE are chromohysteroscopy, methylene blue dyeing of endometrium during hysteroscopy, bacterial culture, molecular techniques such as PCR, RT-PCR, and NGS. Presently, chronic endometritis and vaginal infections seem to be routinely investigated by 85% of clinicians, even with the limitations to histology in general. Lack of standardization of threshold of plasma cells. We don't have standardization that how many plasma cells should indicate that this is high. Should it be more than one, or should it be more than five? And with studies with small number of patients which have no controls, still we are tending to treat and investigate for this. So assessment of chronic endometritis can be considered, and if CE is diagnosis, treatment with antibiotics can be considered. But here I would not say that assessment of tuberculosis can be considered. And if it is diagnosed on these tests, treatment with ATT should be considered. It should only be considered if we do a proper bacterial culture or histology and a laparoscopy to say that, yes, this is tuberculosis. So unexplained RIF and endometrial scratch, when we find nothing is working, what do we do? So how does scratch lead to increased probability of pregnancy? One theory is that endometrial scratching causes some sort of inflammatory response. You scratch your skin in the arm and you will find a red inflammatory line which forms. As it is And it is likely that wound healing response following scratch improves cytokine release of the endometrium and makes it more likely for the embryo to implant and create a pregnancy. So endometrial scratch, what is the evidence? So many studies said, yes, it's good. So many studies said, no, it's not good. There's no effect. Then in which year was this? In which year? In 2018, there was fertility sterility had a systematic review of all the trials which were relevant, and they said that yes, endometrial scratch injury may improve IVF success in patients with two or more previous ET failures undergoing fresh ET. So they gave a very different view. They said in fresh ET it will work, and the ESI timing and technique seems to play a crucial role in determining its effect on embryo implantation. But then came in the PIP studies, People for Pregnancy. And this was a trial which started in 2016. And they said, we have to find out, because it appears that this is a very easy test. Just put in a pipple and scratch it and say, next month I'll do an embryo transfer. But should we really be doing it? We are producing endometrial injury. We are producing a foreign body inside. We might just initiate endometritis for this patient. Are we doing the right thing in sort of interfering with such a sterile uterine cavity, which is like, I would not even do a hysteroscopy for any of my patient. I wouldn't want to go into the endometrial cavity unless extremely necessary. And this was a randomized trial for endometrial scratching before in IVF. And it was again a multi-center, open label, randomized controlled trial, eligible women who were undergoing IVF, fresh embryo or frozen embryo transfer with no recent exposure to disruptive intrauterine instrumentation. That means they should not have had any hysteroscopy in the last 3 months. Participants were randomly assigned in 1:1 ratio to either scratching by pipple biopsy between day 3 of the cycle preceding the embryo transfer cycle and day 3 of the embryo transfer cycle, or no intervention. And what were the conclusions? Endometrial scratching did not result in a higher rate of live birth than no intervention amongst women undergoing IVF. If you see, it is 26.1 and 26.1 in both the groups, with scratch and without a scratch. This study is from Auckland University, from the University of Auckland, and they are really masters in conducting trials. They do very good, very honest trials. So I feel that scratching should not really have an effect. So we thought that let us look into the 2023 ESHRI guidelines, which has been published in Human Reproduction. This is the latest guideline on RIF. What does it say? And Human Reproduction for Infertility Specialist is one of the highest impact journals. So everything they've negated: screening, hysteroscopy, endometrial receptivity test, immunology test, and treatment both. So what did they agree to? Screening, hysteroscopy can be considered in patients with recurrent implantation failure. Even if your ultrasound is normal, after 2 or 3 or 4 implantation failures, you can think of doing a screening hysteroscopy. Everything is otherwise not recommended. Even testing for immunological test is also not recommended. And giving immunomodulating treatments such as intralipid, IVIG, leukocyte immune, LIF, leukocyte immune factor, uh, PBMCs, and anti-TNF are not recommended. And you do not even test for them. Then again, you look at PRP, endometrial scratching, flushing of uterus, stem cell mobilization, steroids, and electively freeze. Everything is not recommended by them. And what is recommended? So we went into their good practice recommendations. If you suspect RIF truly, follow up with RIF specific investigations, and these have been divided into 3 groups: recommended, can be considered, and not recommended. Let's see what is not recommended. Vitamin D testing, microbiome profiling, peripheral NK cell testing, uterine NK cell testing, uterine T lymphocyte assessment, assessment of blood cytokine levels, HLA-C compatibility, mitochondrial DNA content, and DNA fragmentation and FISH analysis is not recommended. Now we come to what is recommended. Reassessment of lifestyle factors. Look that they're not diabetics, the sugars are not high. Are they too obese? Do you want to reduce? I mean, obesity we cannot reduce, but we have to do with it. So lifestyle factors, are they on a smoke or drug or something? Reassessment of endometrial thickness. Have 2 different observers assess the endometrial thickness and its type. Then assessment of antiphospholipid antibody in cases of risk factors. And what is risk factors? Like, if there is a risk factor where there is a thrombotic episode, then you will definitely do this. But if you suspect RIF truly, then also you can think of doing the assessment of APA and APS. And if it is positive, then only you treat with low molecular weight heparin. And what can be considered? Please consider karyotyping, which we do usually for all our patients after 2 embryo transfers fail. Then 3D ultrasound or a hysteroscopy. They've already recommended that in recurrent failure, you can go for a hysteroscopy. Endometrial function testing. You can think of doing a ERA type of a test, which is endometrial function testing. Then do a chronic endometritis testing. So you see, microbiome profiling is not needed. The AMA or LS test, they've not recommended. But you can do a chronic endometritis testing by looking at taking a pipple biopsy and seeing what is the number of plasma cells per high power field. assessment of thyroid function, which we do usually for all our patients. And the last important thing is progesterone levels, which is in the late follicular mid luteal phase. That is just pre-implantation. If the progesterone levels are low, then we can supplement with this. So having said that, what all can we do? In the recommended one, you will do, after you've done all this, what treatment can you do? You can review estradiol treatment if endometrium remains thin. See why the estrogen is not working. If the endometrium was good in the OCR and it is not good now when you're going to do a transfer, change the route, change the type, add the dermal one. Don't increase the oral dose because it all goes through the liver and cause a lot of changes in the metabolism of the liver. Then genetic counseling where relevant PGT if a chromosomal anomaly is detected. So if karyotypic abnormality is there, then we can do PGT, SR also, or anything else. And genetic counseling is important. That do you want to have a aneuploidy check also. Then what you can consider is antibiotics if chronic endometritis is diagnosed, PGT-A, and blastocyst stage transfer for all patients. What is not recommended, vitamin during investigations, if you've done vitamin D estimation and it is less, you don't need to treat it. It is not the reason for implantation failure. So you don't treat vitamin D deficiency if you've suddenly diagnosed it during investigations. You don't do endometrial scratch. You do not give GCSF. You do not give intravenous intralipid. Do not give immunoglobulin, intrauterine autologous PBMC infusion, intrauterine PRP infusion, intrauterine HCG injections, because all studies have been done for all this. Low molecular weight heparin, GnRH agonist and aromatase inhibitor pre-treatment, and assisted hatching. Nothing is recommended. For all patients, recognize the women couple as an individual. Provide time for questions, information, and discussion. Listen to the facts and the feelings of the patient or the couple. Show respect for the patient couple and their wishes and choices. Use clear but sensitive language. Be honest about processes, outcomes, and prognosis. Apply shared treatment planning in a partnership approach with the patient. Be kind, show concern, empathy, and compassion. Don't have a defensive attitude that, oh, you did not get pregnant. It is not our fault. It is your fault. You did not take rest. You did not do this. You did not do that. No, this will not work. If the embryo is good, you don't need anything. And last of all, I found this article. I was listening to a talk yesterday given by one of our doctors from South India, and I took this. This was a very interesting article published in Fertile Sterile in 2023, July, that is after the ESHRI consensus. Recurrent implantation failure, reality or a statistical mirage? This is the consensus statement from the July 1st, 2022 Lugano workshop on recurrent implantation failure. Look at the true incidence of RIF is extremely uncommon, occurring in less than 5% of couples with infertility. How many reach IVF? Much lesser. So it is even lesser than what it is written here. What is really important is reassurance. Reassure the patient, reassure yourself. Have faith on your lab, on your embryology, and reassurance and continued conventional therapies are warranted in most cases. It would seem reasonable not to assign this diagnosis to a patient unless she has failed at least 3 euploid embryo transfers or the equivalent number of unscreened embryos adjusted to her age. I mean, if she's 40, then maybe 6 embryos or 8 embryos. Given the number of internationally recognized experts in the field present at the Lugano meeting in 2022, our publication constitutes a consensus statement. So they felt that it is so little, don't assign this diagnosis easily, and please do not give therapies, just use conventional therapies, which are normal treatment. I mean, give her progesterone, give her a lot of love and care, and make sure that your embryo is best. What happens is that first 2 transfers, if the patient has made 3 or 4 embryos, generally the best embryo is transferred first, the second best second, third becomes a lesser and lesser and lesser embryo. So give space to your embryology lab also, that just don't jump on 2 embryo transfers and say, oh, they failed, so this is RIF. Having said that, I would say to conclude, unexplained recurrent implantation failure is a devastating reality for some patients undergoing repeated cycles of IVF and a perplexing problem for clinicians. There is heterogeneity in the definition itself, which has confounded the process of consistent study design and data collection, and overall has led to a lack of evidence to effectively guide investigations and management. Last of all, RIF can therefore be considered as an evolving field with a significant need for well-designed research. Thank you very much.
Ma'am, thank you for this comprehensive lecture. Now moving on to the questions.
I think this is very important for our PGs to make a summary of this lecture. And if you get a question on this, suppose the question is only embryo, then only take the embryo part. If it is only endometrium, take the endometrial part. But if it is complete RIF, you can shorten this whole lecture and write it in 3 pages. Yeah.
Ma'am, Dr. Akansha wants to know the cutoff for plasma cells per HIPAA field for
I don't know.
diagnosing chronic
I
endometritis.
just read to you that we have no consensus whether more than one should be considered as chronic endometritis or more than 5. So I don't know. What is your opinion, Akanksha? Tell me.
No, ma'am, here sometimes they suggest to do MI and LS also. But
So
these are
these
very
are just
expensive tests,
suggestions,
which
Akanksha.
you suggested.
No, I don't suggest anything. If my if my histopathologist writes that there is evidence of chronic endometritis, I treat. Sometimes I treat patients empirically when they've had repeated instrumentations of the cavity in the form of DNCs or
Mhm.
whatever. Then it's just doxycycline for 2 weeks. This is what I give them. That is empirical. When I find no other reason and I don't want to do another scratching or another pipil for them. And tacrolimus, pre-ET, and RIFC, Richa, these are all medicines. Whether you use tacrolimus or you use IVIG or you use intralipid, this is all in the air. It is, you can use anything anywhere. I mean, if you want anti-aging, there are hundreds of products. Which one will you use and which will stop anti-aging? You do not know. So RIF is also a condition like that. Just transfer good embryos and the patient will implant. There would be maybe 1 in 100 who may not implant even after transferring 4, 5 good embryos. In women over 40 years, they've said that you start investigating after 6 embryo transfers fail if they are untested embryos. So please do not start using these drugs just empirically. They are very expensive. They have late side effects. They have immunomodulating capability, and these patients may suffer for any with any immunological disorders later in life.
Ma'am, Dr. Richa is also asking that are all oral estrogens effective vaginally?
No, I don't know. I started using Progenova after one of my PGs told me, I mean, who was my PG and now she's practicing very well. She told that they use vaginally and some patients really responded well. But all do or not, Jatin Shah's junior came and he said we use Estrabet also vaginally. I don't know whether it will work or not because I've not used it. I gave it to one patient. She had some itching or problem. So I said, okay, don't take it vaginally then. But the products don't write that use it vaginally, except estradiol valerate also writes. Is that right? Anyone knows, Bhavani? Does estradiol valerate write that you can take it vaginally?
Oh, ma'am, I don't think that it writes so, but there are
Mm.
studies on estradiol valerate being used vaginally.
Use
Very few
vaginally.
studies, but
So
on
other
valerate
oral
there are studies.
estrogens, which are the other oral
Ma'am,
estrogens apart from hemisuccinate and
hemihydrate claims
Hemihydrate,
to be
yes.
used vaginally.
What is hemihydrate?
Hemihydrate, they claim that it should be.
yeah, say again.
Ma'am, they claim, but
Hmm.
when they launched hemihydrate, that the advantage of using, I mean, the launching of hemihydrate is it can be used vaginally also.
Very good. So, Richa,
So it
I'm
might
very
be a
glad.
marketing gimmick or whatever.
Let us read the review of the product and please put it on this forum. We'll all be more knowledgeable and then we'll use it with more confidence. Abhi, I just heard in a conference that Jatin Shah's junior came and he said, we are using it vaginally very happily. You see, vaginal estrogens are so much better than oral because vaginal directly goes to the uterine pass, very little goes to the blood to be metabolized by liver, whereas oral, everything, first degradation is in the gut, so the drug becomes less. Then it goes through the circulation to the hepatic circulation. There it is degraded into estriol, which is estrone and estriol, which are much, much weaker estrogens. And hence, by the time it reaches the uterus, very little of active estrogen is left. So, vaginal would be a delight to use for patients also, and especially those with thrombotic conditions or with liver conditions would be very good to use them vaginally.
Ma'am, Dr. Richa also wants to know your opinion on the use of embryo glue for RIF.
I don't know. We do use Richa. We are also desperate about RIF that if three embryo transfers fail and very good embryos, then we have resorted to using embryo glue also. One patient gets pregnant, the other doesn't. So I really don't know whether that is the answer. And IVIG, truly speaking, Archana Sampath, I have never used in my life. I don't know how, what dose, when to use it. You tell us. Archana Sampath, tell us, how do you use IVIG? Chalo, Yukti, ma'am, we consider use of intralipid L. According to me, absolutely big NO. You see, in LIT, you are activating the immune system of the woman. How are you activating it? By taking the husband's serum, lymphocyte free, and injecting it subcutaneous into the woman. I would never want anyone to do this on my body because I don't want to get autoimmunity of any type. Though they do the APCA cytotoxic study of antibodies, and only if it is negative they inject it. But why would I want an antigen antibody reaction with some foreign antigen happen in my body? And as far as intralipid is considered, well, it coats the trophoblast not to be able to recognize the embryo. But have you ever seen us using intralipid or lit? I don't consider the use of intralipid or lit. If you use it, please do under research setting, have a control group, take the permission, take a number of that clinical trial, and then do it, Yukti. We would be very glad to know the results.
Dr. Monica Margaret wants to know what is the role of sperm function in RIF.
You tell me, Bhavani, you tell her. You study every day. Is there any role that did Ashri say that sperm function test must be done?
No, it's not recommended. In RPL, there is upcoming role of testing for sperm DNA fragmentation. But as of now, in
Because there
RPL,
is a spontaneous pregnancy over there. The sperm has to move forward to select. But in RIF, where you're doing IVF ICSI, you've selected the best sperm. Yeah, Bhavani, I just stopped you from speaking. You were saying something. Say.
yes, no, I was just saying that in RPL, there is evidence
Yeah, correct.
testing for sperm DNA fragmentation. But as of now, in RIF, there is no role. Dr. G. Kasturi wants to know the role of HCQ in these patients.
Very sad, I am using it like as a, जिसको बोलते हैं ना, मरता क्या ना करता, एक लास्ट straw की तरह. HCQ is normally used in patients who have autoimmunity like rheumatoid arthritis or other similar conditions to suppress autoimmunity. When nothing appears to work and the patient is absolutely normal, 3, 4 implantations have failed, maybe HCQs could help, but there's no written role of HCQs in implantation failure. Like you all resort to, medicines which are not really recommended. I also resort to sometimes low molecular weight heparin when 2, 3 transfers have failed, or HCQs when HCQs I don't give in RIF, I give in early miscarriages. Whenever a pregnancy happens and a miscarriage happens, and a pregnancy happens whether natural or with IVF. I probably have used a little bit of HCQ because I heard some lectures, and I've read also, but I don't think it has any big role.
Ma'am, she wants to know
Ma'am,
the dose of HCQ you are using.
Yeah, who spoke? Who spoke just
ma'am,
now?
Tejashri.
Huh, yeah.
No, that the dose of HCQ somebody is asking. It's 200 twice a day that we use.
Huh. If we
And
use it
also,
daily,
if we
not
use
for
that,
RIF, RPL.
not for
The
RIF,
going
but in
regular.
RPL, where the patient has
Yeah.
recurrent early pregnancy losses, that's where we use it. Ma'am, since you mentioned that we use low molecular weight heparin, for the benefit of the listeners, how long do we continue the low molecular weight heparin?
See, ideally, if we use low molecular weight heparin only because of its peri-implantation function, ideally it should be stopped on a positive beta HCG. हम सब डरपोक हैं, हम सब डरते हैं कि कहीं
Right,
abortion ना हो जाए. So I use it till 7 weeks and then stop. Unless the patient
right,
has a history of RPL, then I use it till 12 weeks also. Patients
right,
who were
right.
at 9 weeks, 8 weeks, 10 weeks, in them I use it later, but at 7 weeks I stop it otherwise. Is that right,
Right, ma'am.
Shri?
Yes, ma'am, that's what we do.
What we do.
Ma'am, another thing I wanted you to comment on is that if it's a cycle which we've done HRT maybe twice, all the transfers have been done in HRT, we could change the protocol for endometrial preparation to a natural cycle because
That is
that
the
would.
best thing to do. In fact, I have learned also that
Mhm.
natural cycle gives us a better pregnancy rate, a lower miscarriage rate. So you just have to test the patient in the middle of the cycle to detect ovulation very correctly. And I'll tell you, it doesn't make a difference whether progesterone is exposure is for 6 days and 5 days, the embryos implant. Abhi, very recently, a patient got pregnant where she was refused embryo transfer for many, many cycles at some center, saying that the blood flows were not adequate. I mean, she waited almost 2 years for embryo transfer, and then she came to me, and I just gave her a natural cycle and told her, you go and get an embryo transfer done. And she got it done, and she's pregnant. It's positive. So
Right.
see, don't do much investigations, but do relevant investigations and minimal treatment, natural cycles where you use no
And
med.
just in case we don't have an option of natural cycle and we are doing HRT again and again and the embryo is failing, do you think there is a role of serum progesterone before starting the before embryo transfer? On the day of embryo transfer, if it is low,
Yeah,
would you
we are doing it. One
change
of our
something?
girls, Suhani study said that if progesterone was low, then the pregnancy rates were low. Even Bhavani found that out. But even with very
So
low
in the next
progesterone,
cycle, would you add additional progesterone in that case if she's not conceiving?
yeah, I would add with a lot of
So I
sadness
think
behind. I
maybe
would be very
that's
sad to add.
another approach. Yeah,
Yeah, I
one
would
thing
add.
we could consider.
If I don't add, my team will add.
Yeah.
No one will
Yes.
leave. If the progesterone is lower than 8, then mostly we all have a feeling that let's give a little more progesterone, it will work. And this thing did say, if you saw the guidelines, I'll just go back to that. I'll just show you what it said. I'll just show you 1 minute. Can you still see my slides?
Yes. Yes.
Yeah, I'll open this and okay, where you see progesterone levels later on.
Progesterone levels.
So can be considered that you look at them and if you feel that they are lower, and what we did was in our Bhavani, tell about your study, what you observed, please.
The cutoff found was 8. So if it was less than 8, we did see a significantly lower ongoing pregnancy rate. And in the subsequent study, we supplemented aqueous progesterone to the patients whose progesterone level was less than 8 on day of transfer. But the level depends upon the source of progesterone. We were using vaginal progesterone where we obtained this cutoff. So we were using vaginal micronized progesterone 400 milligrams twice a day. But if you are using intramuscular progesterone or subcutaneous, then this cutoff would be higher. Studies have shown a cutoff of around 20 with the injectable progesterone.
Yeah, and this is very important that the first study where we were looking at the cutoffs where we had 4 percentiles, right, in your study?
Yes, yes, ma'am.
And in the lowest percentile, which was 25% and lower progesterone, the pregnancy rate was good. It was even good with patients who had as low as 2.5 progesterone on the day of transfer. But yes, the overall rate was lower than above 8. But then after, in the last percentile, there was no difference. So very high progesterones made no difference, right?
Yes, ma'am.
So the lower one was slightly lower, or it was significantly lower?
Significantly lower.
Okay, and so in the subsequent one, when we gave injectables, but you see, when you give vaginal, you have lower levels. So even in the later treatment group, we did not change our source. It was only vaginal progesterone to all our patients. But yes, those who had lower, we had to give injectable because we can't increase the vaginal progesterone. So we just gave them injectables. And
Right, ma'am.
there, what
Ma'am,
happened?
one,
The pregnancy rates were similar in both the groups.
Yes, yes. In
Hmm.
Suhani's study, though the sample size was small, but
Huh.
she found after supplementing aqueous progesterone for
register.
these patients, she
Hmm.
found the pregnancy rates became comparable.
Okay, very good. Tejashree, what were you asking?
Ma'am, I was just wanting to know from you for the benefit of audience again that if some patient comes from different center with multiple implantation failures and you feel that there were good quality blastocyst transfers that failed, what
Mhm.
would your prescription look like? Like, what would you advise them?
First thing I would do is if karyotype is not done of both the partners, I would do that. Number one. Number two, I would look how many interventions have happened in the uterus. Depending on that, I would give them a short antibiotic course of 2 weeks and a probiotic of maybe 2 months or 1 month. Oral probiotic and an oral antibiotic. These are two things which I would do universally, and maybe an ERA test if I feel
Error.
the patient is very, very desperate. That, and they did say that you can do this. This is also there. Uh,
Yes.
Genetic counseling and where relevant PGT. No, not this one. Uh, Endometrial function.
Investigations can
Next,
be
yeah, can
considered.
be considered endometrial function testing. So endometrial function is the, I think is ERA only, no? What do you say?
Yes. Yes, it's error.
So they do recommend, and I do this also. Karyotype of both the partners, endometrial function testing, chronic endometritis, whether I test or not, if the history is of too many interventions, DNCs, hysteroscopies, or even people who inject PRP, I think chronic endometritis happens there also. So I would give them a course of antibiotic. And progesterone levels now we've started seeing before embryo transfer, thyroid function we assess and all. So exactly can be considered is seen. And even APS APLA.
Yes.
Do we see APS APLA in RIF? No, I
Not in all patients, no, in
no,
not
we
in
don't
RIF,
see.
unless
Not
they
in
have
RIF. We only see in multiple miscarriages.
RPA.
So
Yeah,
I don't do assessment of APLA in
APA.
these cases. Yeah.
But it is in this guideline it says that if there are risk factors, then you should definitely do, and if the risk factors are not there, then APLA testing can still be considered.
Yes, yes. And you know what? Reassessment of endometrial thickness. How do I do this? Tejashree, tell them how do I do it? We just look at a natural ovulatory cycle.
We just look at a natural cycle. Mid-cycle endometrium is what we look at, just
At the time of
pre-ovulatory
ovulation, and
endometrium.
that is what we know as the normal endometrium. And this is how in one case in patient who underwent hysteroscopy 7 or 8 times, saying that endometrium is not there and there are synechiae all. We found this endometrium and I said something is wrong somewhere and they were going into a false passage. We did a hysteroscopy, went into the right passage, saw the endometrium beautifully, did a embryo transfer. She got pregnant twice. So, a mid-cycle endometrium is very important in a natural ovulatory cycle to assess the endometrium.
Right, ma'am.
Dr. Priya is asking what endometrial preparation method would you use for a patient with 3 embryos and maximum endometrial thickness in 3 HRT cycles of 6.5 mm and a baseline FSH is 15.
You ask her what questions you would want to ask.
I want to know the baseline E2 levels.
Not only baseline E2, first thing is
And
you would
cycles
see
are
if
regular
her
or not.
cycles are
What is the
ovulatory.
range?
if they are not ovulatory, then you can give them
Yeah.
something for ovulation, maybe letrozole or maybe gonadotropin. I think gonadotropin is much better. You can just use a small dose of HMG and make her endometrium on that. And wherever it grows, do embryo transfer. Why will you even want to change anything? If your height is 5 feet, I wouldn't pull you to 5'6". I would consider you the best human being at your height. The endometrium is best for her. On HRT, if it is growing 6, and on OCR, if it was more, every individual has a different way of even measuring the endometrial thickness. My ultrasonologist is very tight in measuring. My ultrasonologist in Gangaram is very liberal in measuring. So everyone has a different way. People who come from outstation say 9 millimeter, very nice endometrium. When we see over here, it's 6.5. So it is very different observer based assessment. Please don't discard your ETs, but if they've had all HRT, go for a natural cycle or a ovulatory ET where you can use some ovulation inducing injection or drug to make endogenous estrogen rather than exogenous estrogen.
Dr.
So
Priya
I would
wants
do
to know.
RIFMA karyotyping, endometrial assessment, maybe ERA, and I would give them, whether I test or not, I might give them if there has been intervention. If no intervention, I will do nothing. Only if I'm doing a hysteroscopy, I'll send the endometrium for a chronic endometritis testing. And now progesterone levels also before embryo transfer. So these are the 5 things I would do. I normally, in recurrent implantation failure, which have happened in my center only, I like to add low molecular weight heparin. I know it is empirical. I know it is not recommended, yet I like to add it from the day progesterone secretes in the body or I give progesterone. Nothing else I add empirically. I've not used any other drug. And HCQs, if I've used, it is only in cases of recurrent pregnancy losses first trimester. Anything else?
There's a question, any role of uterine artery Doppler in RI? You've already answered that.
I'm just telling you, a patient was postponed for almost 2 years from another center with beautiful blastocysts preserved over there. And she said that they always refuse me to do embryo transfer. I'm so tired, I'm fed up. So someone sent her to me and I said, okay, I'll do it. Those clinicians wrote on the paper my name that we are doing this embryo transfer on her recommendation because they said she doesn't want to give you any injection also. She said, no, she's refused. She said, only take Utriva cream once every day. This was a natural cycle. She did very well and she came with a beta HCG of over 1,000. They
Now,
transferred two embryos. So
Dr. Sophia is asking what can be done for recurrent fluid in the endometrial cavity where hydrosalpinx is ruled out and empirical antibiotics have also been given.
can't do anything. I'm so sorry about it. Even I encounter this problem. And I feel that if the fluid is not much, just aspirate it before the embryo transfer. If you've ruled out hydrosalpinx, open hydrosalpinx, you've given an antibiotic. तो इसके अलावा और कुछ मेरे दिमाग में नहीं आ रहा है कि दे सकते हैं. Anyone else? भैया, let us help each
Ma'am,
other.
would you
For
do
this.
a hysteroscopy?
Yes, this is a good
Will you
answer.
do a hysteroscopy for
Yeah, I do
husband?
hysteroscopies when I find fluid persistently in the cavity. So whose question was this?
This was by Dr. Sophia.
Sophia, you can probably do a hysteroscopy and you can do a hysteroscopy. I think this is a good answer. And I think I have also decided on hysteroscopy a lot of times when I see fluid. And it is, you can take a biopsy, you can give antibiotics. And I don't know whether Alice Emma will tell you the right antibiotic, but microbiome profiling, they've not recommended. You can do a microbiome profiling also for them.
Ma'am,
Right? Can we
should,
do
ma'am,
antibiotic? Because one patient just now got a Alice Emma positive and I gave her, they had recommended Augmentin and I gave her that for 7 days, a probiotic for 1 month. So I don't know, we can do a microbiome profiling or not. But hysteroscopy में क्या करेंगे? Hysteroscopy करेंगे, देखेंगे साइनिकिया नहीं है, then we can take a biopsy also, and tell them to rule out chronic endometritis. But then you have to decide on antibiotic. You've already given them antibiotic course. So which antibiotic to give? That these people, Alice, Emma, tell you well which antibiotic will work for her, if there is any. Should we go forget in case of fluid in cavity? Uh, what did you
For
write?
FET, should we go for FET?
I feel, how much fluid is there is what matters. If there's very little, a drop of fluid, it comes at the, extremes of endometrial proliferation also. There is a little liquid layer in the cavity. So if it is there, just let it go. But if it is more, we all feel that the embryos will be floating and they'll never get a place to implant. So it's better to aspirate it out. You can try and see. I really don't have an answer to this. You can try. Hysteroscopy is one thing which you must try if you've already given antibiotic. And if hysteroscopy and the microbiome also comes normal, then you just aspirate and go ahead. Microbiome profiling can be done, Dr. Sophia, and it is done exactly like ERA, but tell them that Alice and Emma needs to be done. Okay? Sophia? Pujita has written, depends on number of blastocysts available to patient also. If more numbers is there, then we can transfer one by aspirating the fluid. Very correct. If it fails, then don't transfer others. Do a hysteroscopy, do a microbiome profiling, and see what to do. Okay?
Thank you so much, ma'am. We have had a very good discussion.
Yeah, I know. I'm very happy that, whoever joined, all were interested in this. And we have such little answers, like you don't have an answer to thin endometrium, a normal thin endometrium. We don't have answers to RIF. But RIF is very rare. Mostly patients who are considered RIF are recurrent IVF failures and not implantation failures. Because sometimes I get the other day a patient came to the OPD and she was crying and I said, क्या हुआ फेल हो गया? बोली नहीं मेरा 6 एम्ब्रियो ट्रांसफर फेल हुआ है और आज मेरा पॉजिटिव आ गया पहली बार. She came to our center and her first embryo transfer was positive. There were two patients subsequently who came, one which had two embryo transfers failure elsewhere. So it is mainly IVF failures because I did nothing. A natural cycle, one progesterone and one folic acid. No other medicines were given. So please understand that try to use minimal medicines, use her natural resources more, and you will succeed. And your lab has to be very good. Your embryos have to be good.
Ma'am, when you said I did nothing, it was actually the magic wand of Dr. Abha.
No, no, it is no magic wand. I'm very pleased. Like, not today, yesterday or day before yesterday was like a day of pleasant surprises for me. I had OT also. In OT also, Bhavani, you remember that girl, the
Asherman, we did
hysteroscopy we
four
did?
Ashermans. Uh, because
And she
at the
had
end of
three
it,
attempts at hysteroscopy
cavity
and they
after.
could not open up.
Yeah.
And we opened the whole cavity with both the ostia seen beautifully. So yes, she is post tuberculosis. So I don't know how much will regrow. We will take her for the stem cell thing also. And she came from Dubai, this patient. So that day was a very good day because that patient from the other center who had embryo transfer came jumping that I'm pregnant. Then another AID patient who had a IVF failure, and I said, now when they've used donor sperms in IVF, let us do a AID for you. And she conceived. So, there were happiness moments. Their happiness becomes our happiness. So if you do less treatment, less things given, it works better.
There were a lot of questions, ma'am, which I skipped, which were on use of different immunomodulators, IVIG, GCSF, isolone. So just to
I,
give one answer,
yeah,
that we are not
yeah.
using any of these because there
Yes,
are no
please give
evidence.
an answer. Yeah, there's no evidence to
No
anything.
evidence.
And one anecdotal case can always be pregnant anywhere with the use or without the use. So we are not going to change the patient's immune system for her life by using these drugs in conditions which are not life-saving. Yes, if she has some bad neurological condition, any other autoimmunity, I would gladly give her IVIG, but not for RIF. Right?
Yes, ma'am. Thank you so much.
Thank you. Thank you, everyone. And please put that thing, the what is it? Endofert
And endofat edge.
edge. Please put a label of that yes, it can be used vaginally. Then I'll use it vaginally. It is your product only, right?
Yes, ma'am.
Can
Actually,
it be
for
used
vaginally,
vaginally? Tell me.
madam, for vaginally, one has to go for DCGI. So vaginal use will be off-label use. In fact,
Oh,
so in prescribing information, even any estradiol preparation are for HRT, hormone replacement therapy. All the tablet estradiol, whether it is Valerate or whether it is hemi-added, they are approved by DCGI for hormone replacement therapy. The use is off-label in frozen embryo transfer cycles. Otherwise, approval for DCGI is HRT.
okay. Very nicely said. I'm very glad that it is off-label use, but we have to still read about the product and see whether the product information, not on the label of the product, but just looking at estradiol hemi hydrate, right? Whether it can be absorbed vaginally or not. But Jatin Shah is using it and he
Yes,
does a
ma'am.
lot of IVF. So I
Endofat
think
edge dissolves very easily, ma'am. It dissolves very easily.
we are using a lot of it orally, but I don't know vaginally.
Yes, ma'am.
So someone find out and put some information. Thank you very much. Thank you, everybody. Thank you, Vishal, for this opportunity for us to learn and teach.
Thank you, ma'am.
Okay, bye-bye. Good night.
Support him end the meeting.
Yes,